Bedwetting is quite frequent. At the age of 7 years, there's about 10–12% of the children bedwetting. And about 1/3 of them do have severe bedwetting. Bedwetting is caused in children by three major causes. One is the nocturnal diuresis volume, that in children with bedwetting can result in nocturnal polyuria. That means they are producing more urine than can in a normal bladder during nighttime. The second cause is the bladder. Bladder can be too small overnight to keep a normal volume of bladder volume. And then the third is abnormalities in circadian rhythm, and especially in sleep, where those children do seem to have a decreased arousal because they are not waking up as a reaction on their full bladder. Nocturnal polyuria is a little bit an artificial definition used by clinicians and especially by researchers. But it means that where a normal child overnight makes always a quantity of urine that can within a normal bladder, reason why children are becoming dry by sleeping through the night and not by waking up, there is a subgroup of patients who are producing much more urine during the night. So it cannot be within their bladder, so they have or to wake up, what's nocturia, but that's not a natural method in children to become dry, or they are continuing to be in bed. I think on this topic there's a lot of evidence. I think it's in the subgroup of patients with monosymptomatic enuresis, so in patients without evidence for bladder dysfunction, a large majority of those children do have this kind of disorder, where they are producing too much urine, reason why they are not becoming dry. And reason why a logical therapy is to treat just the nocturnal polyuria to come within normal ranges and so to achieve dryness. This is a difficult question because according to the international standardization, small bladder capacity is not taken in account as a criterion, but we are looking to much more into the symptoms of a small bladder, like urgency, frequency, postponing. But I do believe that indeed another parameter is just the voided volume. Because bladder capacity as such we cannot measure, so we can only measure the volume the child voids. If that bladder volume is too small, well, it's clear it cannot hold a normal diuresis volume overnight, and the child will wet his bed also. Well, there are several reasons, of course. I think, first of all, we should consider bedwetting as a disease and not as a condition that spontaneously goes over. But it's clear that there are two major groups of reasons to treat it, besides just treating bedwetting. I think the major reason is that it gives on parents and on children an enormous burden. The self-esteem in the children is decreasing. It does interfere with the relationship between the parents and the child, and many of those parents become very intolerable to their child. So we should treat that. It's no reason why children should suffer from a disease where they can personally nothing to do for. I think the second thing is also that there is more and more evidence that besides only effect on psychological items, there is also enough evidence now that it influences negatively the quality of sleep, and that by that it influences also cognitive functioning during daytime. There have been numerous publications demonstrating that there's a relationship between nocturnal enuresis and attention deficit, but recently there are a few papers who have demonstrated that attention deficit symptoms ameliorate if the quality of sleep ameliorates and if the enuresis disappears. This is the classical theory. I think if you have mild enuresis, so let us say less than 2 times in a week at the age of 5 years, well, the majority will grow out. That's true. Of course, this is not a group of interest because everybody knows if at 5 years you have mild enuresis, it's not to be taken seriously. The data of C.K. Young of Hong Kong clearly demonstrated that if at the age of 5 years you have severe bedwetting, that means 7 on 7 days, that you have less than 50% chance that it will disappear before adult group. So only 1 of 2 children will, over a period of 15 years, recover from their disease. I mean, this means that a wait-and-see attitude is really not defendable. Well, I think to understand in which cases we should go to the rationale. What does Mindrin melt? It decreases nocturnal diuresis volume by concentrating urine. So in a patient who has already maximal concentrated urine, so only a small amount of urine overnight, it cannot work. In a patient where the bladder volume is too small, well, it can also not work because it's clear desmopressin does not react on the bladder function. So the major indication for the drug is in the patient who has a normal bladder function and a normal bladder volume and who has high diuresis volumes overnight, the so-called nocturnal polyuria. Well, I think that there are several benefits. First of all, in small children who cannot swallow the tablet, the melt is an easy way of giving it. Second is that the tablet should normally be given on an empty stomach. But if we are looking to small children, and I mean under the age of 10, the time between evening meal and sleeping time is rarely more than 2 hours. So they should get it 2 hours after the meal and 1 hour before sleeping time. That's not realistic for the tablet. Since the melt is probably reabsorbed to a large extent in the oral mucosa or in the esophagus, we do not have that disadvantage of nutrition to the same extent. So in the smaller children, it's clearly better. It's also preferred by the children above the tablet. So I think we have also to take in account what the children do prefer. Now, there are also some more scientific reasons. In a recent study, we were able to document that both the pharmacodynamic profile, so the concentrating capacity, the time to reach maximal effect and the duration of action, as well as the pharmacokinetic profile of the melt were superior to the tablet, although it's only almost half of the dose. So I think if we take that pharmacodynamic and kinetic studies in account, that's another argument. And in the same follow-up study of those patients, we saw that patients that were not responding on the tablet had an increase of response rate of about 50%. So in children is the melt clearly preferable to the tablet. Well, our recent sleep study, where we have only published so far a few abstracts, wanted to demonstrate that by treating enuresis, we are not only treating enuresis, but also the psychological consequences, but probably also the abnormalities in sleep and in attention deficit symptoms. And although this seems to be very high targeted to get so easy, we were very surprised that we had indeed on the 4 parameters significant amelioration. Our children did not only become more dry, what we had expected, of course, but the second was that in this group with only nocturnal polyuria, because it was a group without persisting bladder dysfunction, in this group with nocturnal polyuria, we saw a decrease of the nocturnal diuresis correlating with effect on enuresis. We saw an amelioration of the sleep, and really a significant amelioration where in 2/3 of the patients there were much less restless leg syndrome. But if we look to the attention deficit score, so the quality of concentration during daytime of those children, both by the parents, by the child, as by the teachers, it was significantly increased. So we do believe that nocturnal enuresis should not only be treated for the bedwetting also, but because it has positive influence on many other parameters who are so important for the child.